Good afternoon, and welcome to our 9th webinar in our Integrative Practice Webinar Series. My name is Deb Hill, and I'm on staff here at the Collaborative, where I help facilitate our working groups and our projects. So this webinar series is an outcome of the work done by our Integrative Practice Webinar project team, and we want to thank all of our interprofessional team of volunteers for all of their work. So thank you all. So this is some of the topics that are covered in the series are models of integrative care, collaboration, communication techniques, patient management, challenges, innovations. So there's a whole series, and actually you can see all the rest of our series on our website. They are all recorded underneath our working group presentations. So without further ado, I wanted to go ahead and introduce our own Integrative Practice Webinar team member, Pattrick Battaglia, who is a clinician with Logan's Integrative Health Centers and an assistant professor of radiology in the Doctorate of Chiropractic program at Logan. Dr. Battaglia's clinical interests include assimilating chiropractic care into traditional multidisciplinary medical settings, which is exactly where we end up in this webinar today. So I will let you take it away.
All right, great. And I'm just going to keep talking and let me know, I guess, if you can't hear me. And I guess, Deb, you'll have to advance the slides if that's okay. All right, well, thank you for the invitation, and a special thank you to my colleague, Dr. Kernan, for agreeing to do this as well. And we're going to be discussing the topic listed here in sort of a two-part fashion. Dr. Kernan and I both see patients out of a community health system across the St. Louis region, so we're going to be providing that unique lens by which to discuss integrated care, in particular of chronic musculoskeletal pain. Yep, if we can go to the next slide, please. Thank you. So integrated therapies are needed in particular for chronic conditions, because they represent emergent sort of complex phenomena that are more than just the sum of the parts. This is particularly true for chronic musculoskeletal pain, which I spend the majority of my time treating. So this demands integrated therapies, preferably within the patient's medical home amongst different clinicians, primary care, chiropractic, etc. And I'll speak a little bit to that, but then it also demands integrated therapies intrinsic to each clinician, each provider, which is what I'm excited for Dr. Kernan to be presenting a bit more on today, how one clinician can perhaps exploit more integrated therapies in the delivery of care of the patient. So any chronic condition, whether it's pain or otherwise, are emergent features that demand integrated therapies both between and within clinicians. And just as to illustrate that point, this is becoming more and more clear, at least in the world of musculoskeletal pain. What I put here is a recent figure from a publication in the European Journal of Pain, and it's becoming more and more understood that at least pain complaints, but we could probably delete pain and put in another clinical feature here, whether it's diabetes or what have you. These are more driven by the phenotype of the patient and not necessarily individual biomedical constructs. So what you see in front of you is a graph representing patients who suffer from acute to chronic pain, or patients that recover. And if you just compare two different phenotypes of people, phenotype 1 is that little blue circle in the center. These are patients who get better from an acute pain episode, and you can see this cluster of people, regardless of pain location, whether it's low back or knee or what have you, they suffer from lower pain intensity, shorter pain duration, they have better recovery expectations, they're less distressed, they sleep better, and they're more physically active. Contrast that to phenotype 5, that purple circle on the outside. These are patients who had an acute painful episode and then went on to develop chronic pain, and they have low physical activity, a high number of pain sites, greater distress, and so on. So this graph is just meant to illustrate the point earlier that chronic conditions are sort of complex, and they're more phenotype driven. That requires integration for example, in pain, addressing all the things you see up here, activity, work, sleep, distress, etc. But other conditions as well require this integrative approach to care, as we'll continue to discuss today. And integrated care and integrated opportunities can sometimes be problematic, in particular in a community health environment because of resources. So what I've listed here are sort of a way to share perhaps some successes we've had locally to expand integrated opportunities amongst different disciplines. And these include, of course, academic partnerships. We maintain a strong academic partnership between Logan University and Affinia Healthcare, which has expanded to include not only chiropractic, but occupational therapy and now a nutritional therapy as well. But in addition, I'm going to acknowledge just a few local, regional, and state advocacy successes that are working to expand integrated opportunities and might serve as some material for those on the call that are interested in expanding integrated opportunities, especially in a community health center environment. So with respect to academic and clinical partnerships, as mentioned, we maintain a strong partnership between Logan and Affinia, and this is definitely a bi-directional partnership. If we can go to the next slide. I wanted to give a little bit of patient data just to who we see within Affinia as chiropractors, and then maybe compare and contrast that to who the average chiropractic physician is seeing in private practice, just to illustrate that expanding these clinical opportunities for myself and my students will definitely go a long way to the betterment of the profession in general. So you can see some of the patients that we see here, 90% at or below the poverty level, 70% African American, and then diverse backgrounds, including Spanish and other languages spoken as well. These are the patients we're seeing within the Affinia healthcare system. But we also serve as a good outlet for the complaints listed here. A lot of the patients I see suffer from either low back or neck or mid back pain, so spine-related disorders, but also other musculoskeletal complaints, shoulder, hip, and knee being the top three. So while we get a good training site for ourselves and our students, and we expand access, we also serve as, I think, an effective outlet for these conditions. A number of our patients have comorbidities. The top ones are listed here: obesity, behavioral disorder, hypertension, asthma, COPD, and diabetes. So again, and actually if we go to the next slide as well, that'll, I think, solidify the point. These are patients who might be more complex and medically complex than the average chiropractor is seeing, and a different patient population, which I think is good for future growth within the profession. So this is just a snippet from the literature on who chiropractors are seeing, in particular in the province of Ontario, but we can extrapolate it in general. And these academic partnerships with more diverse sites provide a very diverse avenue for training for our students. And lastly, from an advocacy standpoint, there have been a few recent developments in the past year to share with respect to complementary and alternative approaches in chiropractic in particular. So Missouri Medicaid has now approved coverage for chiropractic care on a standalone or as part of a chronic pain initiative that they have. So they cover a certain number of visits in a reimbursable fashion. That will better enable expansion of chiropractic care and associated services into these community health and similar environments. So there was a lot of advocacy to acknowledge. I was not a part of it in any fashion, but nonetheless, a lot I wanted to acknowledge for those that were. These are really big wins that will further enable and entrench chiropractic integration going forward. And then locally, you can see here a gateway to better health is acknowledged, and in particular, I want to acknowledge two players within the St. Louis Regional Health Commission who fund Gateway to Better Health. Gateway to Better Health is a bridge type of healthcare coverage local to the St. Louis area as a bridge for patients to get onto Medicaid. And through the efforts of two individuals in particular, Ms. Amanda Harris and Dr. Heidi Miller, they've created what's called this Beyond Pain STL initiative. We're now starting, if we can go to the next slide, effective next year, January 2021, they've procured coverage, financial reimbursement as part of the per member per month coverage to health centers to support further integration of chiropractic, occupational therapy, and physical therapy as part of what they deemed a physical function experts. So those of us that are helping patients with their spinal and musculoskeletal complaints. This takes effect in January 2021. So it's another example of an advocacy type effort that will go a long way to improve integration locally. All right, so that was a little bit about the advocacy, or sorry, about integrated care sort of between clinicians, and just a little bit about where we're at locally with our academic partnership and with, I guess, the state of integration is locally within the community health center. But as mentioned, integrated therapy is beyond just integration amongst people. It can be integration internally as far as the therapies provide. So I'm really excited to turn it over now to Dr. Kernan to discuss a bit more about the integrative approach and his approach to care. Dr. Kernan is board certified in both family and integrative medicine. He applies a functional mind-body medicine approach to help his patients heal the root causes of their chronic illnesses. He has worked at Affinia for 28 years, probably over 28 years now, and serves as an assistant medical director. So again, thank you, Dr. Kernan, for agreeing to do this. And without further ado.
And thank you, Pat, for inviting me to participate here. And the introduction, I'm delighted to be here to share about what we're doing in our inner city clinic and how we're collaborating and how we're making an impact for our patients by applying this integrative approach. So, you know, with the complexity of chronic pain and all the comorbidities that so many of our patients have, a few years ago at Affinia, we decided to comprise a chronic pain team, kind of multidisciplinary chronic pain team, and set up a special schedule so we could have longer visits with patients and have team huddles. You know, basically a patient comes for initial visit and they see a number of us at the same time on the same day. So we're putting our heads together along with the patient about what's going on with them and how we can help them start to get better. So our chronic pain team, so these are all people in our primary care clinic. So we have our chiropractor, Dr. Battaglia, you know what he does. We also have a clinical pharmacist who joins us for these chronic pain sessions, and she takes an extensive medication history and drills down on the details of current usage, has recommendations about conventional medical therapies. We also have a licensed clinical social worker with us on those days who can do an extensive mental health evaluation and especially evaluate the social influences on the patient's well-being, you know, positive and negative, what limitations they have, what resources they have. We also have a nurse on our team. The nurse tracks down records and tracks referrals, but also serves as a coach for dietary interventions that I'll go into shortly. We have the MD, that's myself. I'll speak about that in a minute. And we have, you know, ability, especially through Gateway Medicaid, to refer patients for specialty services, diagnostic and therapeutic, outside of our clinic. So that's our chronic pain team. So as Pat's invited me, I'm going to focus in on the role that I take on that team, applying this functional medicine to patients with chronic pain. So, you know, this is a systems biology approach to addressing the causal and perpetuating dynamics that are going on within the person's system and subsystem, you know, that are contributing to their ongoing pain. And I want to give a shout out really to all of the chiropractors and naturopaths who over the last 3 decades have really been leading all the health professions in developing this functional medicine approach. So with this approach and this understanding, this systems biology understanding, there's really so much that we can do to impact a person suffering with chronic pain. And so over the next 15 minutes, I just want to sort of survey the field of what I do with patients, and including, some details on how these elements of the approach make a difference, and also how they are doable in our low-income setting, where almost all of our patients have very little disposable income, just very little financial wiggle room. But even so, there's a lot that we can do that has a zero net cost to these patients, or has a small cost. So one big area that I address with all of our patients with chronic pain and any chronic condition really is inflammation. So at one level, I'm talking about systemic inflammation as a perpetuating dynamic in any chronic pain condition. The more systemic inflammation there is, the worse any kind of nociceptive pain problem will be, the worse neuropathic pain is going to be, and the worse central sensitization is going to be. So lowering systemic inflammation is an important lever. And the primary mode of action here is diet. So the typical diet, typical American diet, and typical diet among many of our patients is one that increases inflammation because it's not good for the gut. Paucity of vegetables and fruits, excess red meat, high temperature fried foods, high sugars, all of these things impair the intestinal membrane and allow lipopolysaccharides from normal gram-negative bacteria to enter the circulation and increase systemic inflammation throughout the body at any local site of inflammation, and also at the brain, in the brain. So this typical diet is also high glycemic, and high sugar causes high insulin. Insulin promotes inflammation by upregulating the production of pro-inflammatory prostaglandins. So what can we do about this? Well, this is one of the areas where we really can apply kind of a zero net cost approach to helping a person eat differently. So we can substitute fast food, fried foods with more vegetables, and they don't have to be organic vegetables. Like cauliflower and broccoli and cabbage are all on the Clean 15 list from the Environmental Working Group. And these crucifers really are superfoods. They induce antioxidant enzyme systems in the body. They enhance, upregulate, detox enzymes in the body. All of this decreases systemic inflammation. We can help people shift from eating processed carbohydrates to eating sweet potatoes and vegetables and beans, legumes, helping patients get back to cooking some beans. So these are low cost options that our patients can adopt, and they do adopt to their benefit. So food is always first, but then there are simple, powerful, inexpensive nutritional supplements that can augment an anti-inflammatory diet. So vitamin D is crucial, and almost all of our patients are low in vitamin D. So I'm always seeing vitamin D levels, in the teens, but for only $2 a month, a person can take 4,000 to 5,000 units of vitamin D and get their level up over 50. That's what we want. Fish oil supplement is very helpful. Again, for $2 a month, a person can take in 1,000 milligrams of EPA and DHA on a daily basis by getting fish oil from Costco or Walmart. And so I just want to say that whenever I'm recommending any nutritional supplements to my patients, I'm using Consumer Lab as a resource. Consumer Lab does independent third-party testing of nutritional and botanical supplements to evaluating them, testing them in their lab for quality and purity, and then they do price comparisons. So everything that I'm going to mention, every nutraceutical I'm going to mention is a specific product that Consumer Labs has tested and approved and recommended and available at these costs. So I mentioned vitamin D, $2 a month, fish oil, $2 a month. Curcumin inhibits cyclooxygenase and lipoxygenase and nuclear factor kappa beta. And you can get good curcumin for $14 a month. So we have lots of patients with chronic pain who are buying over-the-counter ibuprofen and acetaminophen and paying that much. You know, Medicaid does not cover these over-the-counter. It does not cover acetaminophen over-the-counter, for example. So all of these are practical, doable anti-inflammatory strategies. So we try to get patients off of NSAIDs, for example, you know, whereas there's evidence that NSAIDs could be effective for a few days, maybe 2 weeks max. There's no evidence that NSAIDs are really helpful for improving pain applied chronically. And whenever I can, I'm trying to get patients off of NSAIDs. So whereas an immediate effect of the NSAID may be analgesic for some hours, at the same time, the NSAIDs are causing a mild enteropathy, an increasing intestinal permeability, increasing liposaccharide getting into the systemic circulation, increasing systemic inflammation. You know, so there are other options. And head-to-head in randomized controlled studies, Boswellia, for example, that's Indian frankincense, Boswellia resin extract, available for $12 a month, is as effective as NSAIDs in decreasing pain without the adverse effects, you know. So the NSAIDs are a common conventional medicine trap that we can help our chronic pain patients out of. Curcumin, you know, also inhibits cyclooxygenase, lipoxygenase, and also effective in that way. Ginger is another one. So we're trying to use these immunomodulators that help restore balance in the immune system without causing other problems. So also in terms of inflammation, I do a lot with patients who have chronic pain, identifying triggers of inflammation specific to them and their conditions. So we have a number of patients, for example, with rheumatoid arthritis, who, working together with them, have identified specific food protein triggers to their immune system activation. I have, I don't know, 8 or so patients that were on multiple drugs for lupus arthritis, rheumatoid arthritis, who now are symptom-free off drugs by simply avoiding an offending food. So we apply this elimination challenge diet process. Again, this is not some expensive functional lab testing process. It does not cost our patients money. We get them to avoid eating the 8 most common offending proteins. That's gluten, dairy, soy, peanut, egg, chocolate, unfortunately, coffee and tea. Anyway, for 3 weeks, and many of our patients experience improvement. And then we challenge each of those foods apart from the rest to figure out which ones are the troublemakers. Most people have more than one offending protein, which is an indication, again, of impaired intestinal barrier function. And so we undertake some gut rehab with avoiding the offending food proteins that we've identified, fish oil, vitamin D, a simple multivitamin that has vitamin A and zinc, and glutamine, or glutamine powder, $12 a month. So for a couple months, this gut rehab program, and most of their food triggers resolve. Maybe actually pretty commonly gluten remains, but then we teach people how to eat without gluten. So we've had a lot of remarkable improvement with addressing inflammation. So then we also have in the functional medicine approach attention to metabolic functions in the body. And so you're probably familiar with how we can do metabolic resuscitation of the nerves, the peripheral nerves in patients with diabetic neuropathy. So this is just an example of a common neuropathic pain condition that really responds well to nutrition. So activated vitamin B6, B9, and B12, some alpha lipoic acid over the course of 9 months reverses diabetic neuropathy in a majority of patients who have it. It's not common for me to have a patient who's willing to undertake a vegan diet, but that also has good evidence for improving diabetic neuropathy. A lot of people are not aware that a lot of our outpatients with chronic illness, including chronic pain, specifically fibromyalgia, migraine, also depression, are in a state of the sick euthyroid syndrome. So this is a condition in which the body is having difficulty converting levothyroxine, which is really a pro-hormone, to the active form of thyroid hormone, T3, that's liothyronine. And sick euthyroid syndrome is recognized in very sick ICU patients, and it's treated all the time with liothyronine, that's the active thyroid hormone. But it turns out that there are many people in the outpatient setting that are not critically ill, but they're chronically ill, and they also have the sick euthyroid syndrome. So we can identify this with checking free T3 and reverse T3 levels. And when a person is in this inadequate thyroid state, we can try addressing what's causing it. That's nutritional insufficiency, maybe excess toxins, excess stress. And we can also supplement with liothyronine. And as you know, there are good studies on liothyronine improving, for example, migraine and depression. So specifically with regard to fibromyalgia, there's been considerable work done that reveals how a significant proportion of people with fibromyalgia are having that experience. They're expressing fibromyalgia. Fibromyalgia is their expression of a sick euthyroid syndrome. And I have a dozen patients with fibromyalgia that melted away when they got appropriate T3. Hormone balance is another area that is useful to apply in our systems approach to people with chronic pain. So it's very common for women to have an excess estrogen, high estrogen state. Well, excess estrogen enhances cyclooxygenase. You get more prostaglandin E2, more inflammation, more pain, and we can lower estrogen levels through diet. Again, we have our superfood crucifers that enhance the promotion of estrogen detox and elimination. And a lower glycemic diet goes a long way to lower estrogen levels as well. Patients who end up, men who end up on opioids, 70% of them develop low testosterone, and that makes them weaker and fatigued and depressed and less motivated. And we can check that out. And we have in our pharmacy, even for patients who don't have Medicaid, patients with gateway or self-pay patients, for $13 a month, they can get liothyronine, they can get testosterone as appropriate. So I've talked about inflammation as an area, metabolic as an area, and just to touch a little further on a functional approach to central sensitization to pain. And this is an active dynamic in many of our patients with chronic pain. Well, we know that systemic inflammation activates microglia in the brain, and that increases inflammation. We know that, and is proposed to be one of the mechanisms of central sensitization. Nutrition, I talked about nutrients and nutritional adequacy. It's probable that some mitochondrial insufficiency in neurons diminishes their resting membrane potential, making it easier for them to become depolarized. And this can be a mechanism for non-dampening of pain signals or amplification of pain signals and central sensitization. So migraine is, one condition that has been very well studied, very extensively studied, and an example of central sensitization in the trigeminal neurovascular complex. And there are controlled studies that show that coenzyme Q10 and magnesium and vitamin B2, riboflavin, and B6 and B9, folate, and pyridoxine all can improve migraine. So these are all nutrients, cofactors for mitochondrial activity. Stress promotes central sensitization. Stress creates a neurogenic inflammation. This is a huge area. I'm just touching on it. I'll get into treatment here in a minute. And sleep is a huge factor. Many of our patients are in the cycle of pain interfering with sleep and inadequate sleep, augmenting pain. And so we have a sleep recovery program that combines cognitive behavioral therapy, melatonin. People can get high grade, sustained release melatonin for $4 a month. And so we help a lot of people get better, getting better to sleep. I mentioned food protein triggers and autoimmune disease earlier, but there are also food protein triggers for central pain syndromes. So these central pain syndromes, migraine or headache, fibromyalgia, irritable bowel syndrome, interstitial cystitis, many of these conditions improve with identifying food protein triggers. And specifically with migraine, a lot of people are not aware that pylori, Helicobacter pylori colonization of the stomach can be a migraine trigger. It's actually a very common migraine trigger. And so this is a form of dysbiosis, in the functional medicine lexicon. A lot of people are colonized by pylori, but in some people it's triggering their migraine. In fact, the association of pylori colonization with migraine is so strong that if we take a patient who has migraine and test them for pylori, which we can do in our lab for all our patients, and they're positive, and we apply eradication therapy, quadruple therapy, and after that treatment they still have migraine, the chances are higher that they have failed pylori eradication than pylori is not a migraine trigger. And if we can retreat or improve the treatment, eradicate pylori, migraine gets better. I'd say half the patients who come to me with migraine have pylori, we get rid of it, and their migraine goes away. They don't need chronic medication. So we don't know exactly how that works, but so obviously there's more that we don't know. And then there's the whole area of mental, I'm sorry, I'm looking down at my timer here because I need to leave Pat time we agreed on. But this is exciting to me because there really is so much that we can do that has a positive impact. Okay, so mental pain is involved with central sensitization. So we're talking about trauma. And on all our chronic pain patients, we're doing the ACEs questionnaire. All of our chronic pain patients are beset with losses of income, losses of roles in life, losses of relationships they couldn't keep up with because they couldn't get out, bridges that they've burned. A lot of our patients with chronic pain have malcognition. They're not thinking clearly or accurately about what they're experiencing, over-identifying with their pain problem. Lots of patients with mental pain from isolation as a consequence of their pain, with depression from the stress and all of that impact. Well, depression improves with exercise, fish oil, specifically DHA supplementation, 12 to 14 hour nocturnal fast, meditation. So all of those things increase brain-derived neurotrophic factor, which is part of new learning, which all our patients with chronic pain need to accomplish. They need to change. They need to learn a new way of living because what they've been doing is not working. And those are all inexpensive, practical, doable things that can help them move forward. Curcumin also increases brain-derived neurotrophic factor. So vitamin D also improves depression. So functional medicine, as I've sort of been touching on these different specific aspects of a functional treatment approach to chronic pain, functional medicine applies a complex treatment program to deal with complex multi-system problems. And just as Pat introduced, that's what chronic pain syndromes are. So this is a lot to do, right? There's a lot we can do. It's more than I can do alone. That's why having this interdisciplinary team is so critical, and having the extra time that our schedule affords us to take with these chronic pain patients is very important. And we also leverage the power of group visits. We have a chronic pain cognitive behavioral mind-body group. So all of our chronic pain patients are invited to participate in a once a month session that goes for 90 minutes. A licensed clinical social worker facilitates this group. So this is applying the best of cognitive behavioral therapy for chronic pain, including helping people get a clear understanding of what is their chronic pain and how it's working in their body and their brain, helping them to recover joy and purpose in their life with the abilities that they do have, and disidentifying with the abilities that they don't have, or the losses of those abilities. Every one of our chronic pain group session features 20 minutes or so of experiential learning in a mind-body skill. So this is a number of relaxation practices, also practices teaching or developing mindfulness. So mindfulness meditation with using breathing, using body sensations, mindful eating, mindful movement, like gentle yoga, chair yoga, for example, and then also imagery for mobilizing internal resources for healing, self-compassion, inspiration, imagination, helping people find their own way forward through their difficult situation. And the chronic pain group offers a facilitated group dynamic that helps people to change. So, all of this is sort of a complex team approach to dealing with these complex problems. And reversing the downward spiral that affects most people with chronic pain takes this multidisciplinary systems biology, multimodal approach. Most of our patients have multiple points of leverage for intervention to get their downward spiral to slow down, stop, and begin to reverse. And it's different for different patients. For some people, it's movement. For some people, it's diet. For some people, it's sleep. But we do anything. We take any effective step. And all of these steps involve self-care. So every one of them that a patient experiences benefit from, they also experience the positive effect of self-efficacy, which is something you don't get from a prescription. And self-efficacy and the hope that comes from it is very important. In our multidisciplinary approach, we have a number of different people that are the pharmacist, the chiropractor, the social worker, the doctor, the nurse. All of us are giving patients the message that we believe they can get better. It's like an infusion of hope, and that is also helpful. So we have challenges. The social determinants of health frequently cause fragmentation of our care. We're always often circling back, picking up the pieces and starting over with so many patients. The coronavirus has been hugely disruptive. We have no group things going on at all. We don't have our chronic pain team meeting as a group. We don't have our mind-body chronic pain group going. Huge impact, but still there's a lot we can do. I love working with Pat. It's so complementary. His musculoskeletal sonography expertise is very helpful. It's great. He mentioned the Medicaid coverage, the gateway, resources, our pharmacy, our lab. So even with our challenges, there's really so much we can do. And that we do. And I really enjoy working with Pat. It's so complementary, having his expertise with the musculoskeletal thing. Movement is a key piece for all of these patients, and how to do it well and safely, and how to encourage a home exercise program, how to get an accurate diagnosis of what's going on with their musculoskeletal system. These are all essential, and it's so wonderful to have Pat to work with. Back to you, Pat.
All right, well, that's probably a good place to end with that comment then, but no, thank you. I'm sure there are questions. Maybe I can ask the first question though. That was a lot of practical tips and practical, I guess, translation of something that's much more detailed. To that, what advice do you have for all of us with respect to doing what you can to foster behavior change in your patients to adopt these therapies, et cetera? What other advice might you have, if any, for that?
Yeah, so I'm glad you brought that up, because that gets to what is the heart of being an agent for healing with any person. And so this is a key and central part, in all our professions, and that is to sort of leverage ourselves as agents of healing, which, forging an effective healing relationship with a person. And that always begins with listening and respecting a person's own experience of what they have going on. It's fundamentally adopting an attitude and of being aware and being compassionate with somebody, listening to them, respecting them. So that's sort of a priori prerequisite to sort of engagement. And in that context, a person, can let you know where they are. So, we always talk about taking the history in medicine. Well, it's also helpful to take the future, to ask a person, so why are you here? Why do you want to get better? What's your health? What is better health good for you? What motivates you? Is it to take care of grandchildren? Is it to get back to work? Is it, for different people, it's different things. And what are their aspirations? What specific goals might they have? And what they think is within reach, what they think is out of reach. That part about helping people recover joy and purpose is really key. And so we tap into that and get some traction with genuine motivation, which is an essential ingredient for any self-care treatment plan to work. So a lot of people don't believe that they can get better when they've been stuck feeling so bad for so long. And sometimes in the first pass, we don't get that traction, but we let people know this is where we're coming from. This is what we think is possible for them. And lots of people are willing to try to do something. And so that whole technique of motivational interviewing, that sort of begins with engagement and aspiration. So I mentioned taking the future, like taking the history, and there's also taking the present. So what resources do they have? What's their real current experience? And looking for where is there a point of leverage that can make a difference for them, helping them to understand it, and then encouraging them to try, and then sticking with them, and we have them come back. And sort of every experience is useful learning. So you didn't do that. Okay, you didn't try that. Okay, so what was it like when you were at home and you didn't try that? And what happened? And trying to identify and lower those hurdles, lower those barriers, and try again. So, I didn't even mention obstructive sleep apnea, but almost many people obstructive sleep apnea is really common, and it's often undiagnosed, and it impairs a person's ability to really change their self-care. So often that's a hidden barrier that needs to be addressed for a patient to be able to move. Anyway, so I've been talking for a bit, Pat. I don't know if I'm getting to your question.
That's great. Yeah, no, you can keep going.
Yeah, well, just back to the main point, which is the fundamentals of our professions, using yourself as an instrument, an agent for healing.
That's great. Deb, I don't know if I guess I'll turn it over to you at this point, if questions, or let you run the show from here.
Great, thank you. I'm actually kind of flying blind on the technology end right now. So I think Beth and Mitchell are also on to take a look at some of those questions.
Yeah, just waiting for audience questions. This is Mitchell here, but I have a few, or one or two of my own while we're waiting on that, if you don't mind. Thank you, Dr. Kernan and Dr. Battaglia, for your great presentation. It was really interesting to hear what you're doing, and great to hear about working with underserved populations, and how you can manage to help people that certainly have a lot of barriers to care. I can understand. I work for the Canadian College of Naturopathic Medicine, and we have a number of teaching clinics that work out of community healthcare centers as well. And it's really interesting to hear what you're doing in an integrative model. One of my questions I have is, Dr. Battaglia, you're working with students. Are there other students in your integrative model that you're working in from other disciplines there, or is it the chiropractors students alone? And how are you integrating them into learning about working in that integrative model also?
Yeah, so it is just I work just with chiropractic students. The health center does have different residents that rotate through, but we don't have as much interaction. They kind of stay with their respective discipline, like OB-GYN, for example. But they're part of the care. They're kind of alongside, and so they have a lot of experiential learning in that fashion. So they get a lot of practical interaction with the patients and hear the verbalization of the decision making and the informal conversations that might happen amongst clinicians, and so they're along for the ride.
So they're able to observe other, all of the different members of the teams working with the patients as well.
Yes. Now it depends on, I guess, where we're at in terms of care for the patient, but certainly they spend most of their time with me caring for our patients, and then we all do it under one roof, so to speak. So they see a lot of the other integration in an informal manner.
Yeah, and for myself, I would say, Mitchell, I think there's untapped potential that we have in our setting for introducing medical students, people that are on their way to be MDs, to this functional and integrated, sort of more holistic systems biology approach. So that would be a growth area for us.
Mm-hmm. Yeah, that's great. Always room to grow, most definitely, but it's complex. Do you, wondering if in your system, like who does sort of your care coordination or advocacy for different touch points with different healthcare providers?
Well, some care coordination with the chronic pain patients falls on the nurse. That's part of our chronic pain team. But we also have a number of people and processes kind of behind the scenes that we employ for all our patients, to accomplish referrals, especially outside of our primary care clinic. And so we have a referral team, and I task referrals to them through our electronic medical record, and they're responsible for getting patients those services, making sure we get the records, making sure they happen, the visits happen, making sure the records come back to us, and getting them to my electronic desk, so to speak. But the nurses really, and the site nurses do an awful lot of that troubleshooting stuff when things are falling through the cracks.
Yeah, that can be so important, especially with complex care like what you've described.
Yeah, and it's especially it's very common in the low-income population for care to become fragmented. People getting emergency room visits and getting sort of their care splintered all over the field.
Mm-hmm. Well, on that note, you've talked a little bit about some of those challenges around working with, within an underserved population, let's say, and is there anything else that you're really seeing as like key issues around, just determinants of health or access to care, mental health issues, or even mobility and being able to access care? What are those real big challenges, and how might you be approaching those?
All of the above.
Yeah.
Everything that you mentioned. Patients with transportation barriers, patients with mobility aid barriers, patients with difficulty moving who are stuck living in a multi-level place where the bedroom is upstairs, and they're downstairs. They have a hard time going up the stairs, and they're sort of sleeping in an easy chair, and that's making things worse. I had a patient the other day, just recently, who had no hot water to bathe in, and so he's carrying a 2-gallon pot of hot water up the stairs to pour it into his bathtub so he can shower, and it spills, and he gets second-degree burns on his legs. It takes months to heal. Just one day, he's carrying up the stairs. We everything you mentioned, is a deal, and having food deserts in inner city neighborhoods where we're our clinic is located and where we're seeing patients. So many people unemployed with coronavirus and having low access to food. We have an arrangement with a local nonprofit supplier of food pantries called Operation Food Search that brings truckload of produce to our clinic parking lot every Wednesday, and pallets of fresh produce that we give away to people. And on Wednesdays, there's a line of cars for blocks, for people coming to access these things. So it's everything that you mentioned.
Mm-hmm.
If I can add too, I know Dr. Kernan mentioned the trauma. It's, the desensitization to really impactful traumatic events. Between visit 1 and 2, there might be, a witness of a serious crime or the victim of, and it's just like you and I would talk about perhaps getting a haircut. It's, the level of trauma is greatly impactful. The health too.
My grandson was shot last month.
In the same breath as, something benign, right? And it's
and a lot of things that are ongoing and impactful that are not spoken, that are unsaid, like the sort of population trauma of racism. We see a lot of, like Pat showed the demographics, we see a lot of African American people. Well, St. Louis is a very racist local society. If you look at what happens in the zip codes in St. Louis, there's like a 15-year difference in life expectancy between almost adjacent zip codes in part of our metro area. We have some zip codes with infant mortality that rivals rural Haiti in North St. Louis, and so these are the impacts of racism and economic oppression. Really, there is very present structural racism in the St. Louis local political economy that many of our patients are subject to, and they know it's going on, and it has an adverse impact. It is stressful. Anyway, so all of that is the air that we're breathing, the water that we're swimming in, and that our patients are swimming in, and that we're trying to swim upstream in.
Yeah, that sounds like terribly important work that you're engaged in and help there.
Yeah, and so certainly there are patients in whom the weight of all of that, or the force, the dynamic, the sort of downstream or downward spiral of that kind of torrent of social determinants is more than we can push against, and we don't succeed, but we do what we can. And there are a lot of patients who do experience improvement with our approach. And that's what keeps me going. Yeah.
Mm-hmm. Thank you. Thank you very much.
Mm-hmm.
All right, well, we are just about at the hour here. So I want to take a moment and just make sure that I thank both of you, actually everybody, for joining us today. Thank you all for your time and for sharing your really unique experiences. We will go ahead and we have this session being recorded. We'll get that posted up on our website. And we thank everybody for your time today.
You're welcome, and thanks for the invitation, and thank you, Pat.
All right, thank you all. Appreciate it.
All right, thanks so much, everyone. Bye-bye.
Thanks. Bye-bye.
Thank you. Bye-bye.
Bye.